Thank you, Dr. Ayyappan, for giving me an opportunity in my talk, Posterior Instability. So I directly go into the case present of a professional boxer who was a 24-year-old male, presented regularly to me with a posterior shoulder pain, and he gives me a history of multiple bench pressing. On clinical examination, you could see the typical posterior drawer was positive, and we could see the humeral head nicely going back into the socket. So after doing this routine, what we basically do is take a MRA, in which the MRA showed us, as you can see, this is through which the dye has gone in, and this is the humeral head and the glenoid. This is the anterior capsule, which is intact, and this goes the posterior, in which there is a big sac-like lesion, and with the fluid. Considering this, then going inside the glenoid joint, so the basic position which I do is the lateral position, and my posterior, I always start with the posterior and then go with the anterior superior and followed by the most 7 o'clock or the Wilmington portals slowly. So in this patient, as you can see, there's a big labral tissue mass which has been hanging inside the glenoid labrum, extending from 12 o'clock with lot of frayed tissue present inside labral tissue inside the shoulder joint. So to go with this is the posterior shoulder instability patient, you just need to change your scope. When we address a patient with the anterior shoulder instability, we tend to look from the posterior aspect. Where in case of a patient with the posterior shoulder instability, we have to come with the, we have to look from front. So your approach should be equal, it's completely same. Go with the posterior portal, go with the anterior superior portal, and then you have to bring your scope to the anterior superior portal. It's better you do an anterior inferior portal too, and then use the same posterior portal, which you have done first as a viewing portal, as your working portal. Once you go into this working portal, then the first and foremost is remove all the frail tissues, remove all the fraying of the labral tissues, and once you get a good bed of capsular labral, this glenoid bone and the labral tissues, make the next 7 o'clock portal and then follow the steps of your normal anchored bank repair. Use the separator spreader, spread all the labral tissue from the marge. Again, debride the area properly, use your abrator to get a proper margin of the glenoid labral tissues. And once this is done, then you pass your anchors, again the separator, pass your anchors, and then you can place your anchors. Just you should remember, and just like in case of a slap lesion, we have to keep in mind while placing our anchors. In case of while putting our anchors at 11 o'clock or 10 o'clock, place it on the wall of the on the glenoid wall, where when you go down, you can place it at the junction of the labral capsule. I'd like to show another case of a professional football player who had a complaint of repetitive shoulder pain. In this, after doing a diagnostic scopy, you look for the biceps, the subscapularis, and then when you go posteriorly, you can see lot of frail tissues, which are easily not, then you fail to see the proper margin of the ruptured labrum. As I mentioned earlier, go anteriorly, make the posterior labral tissues, the 7 o'clock portal, try to again probe the tissues, probe the glenoid labral, see the margin, prepare the bed properly as we done, and then pass your suture anchors. So since I practice hip scopies too, so one you can go for the inferior, just as we do for banquet, take a proper bite, use your anchor thoroughly and get a good bumper effect, try to get bumper effect, and a minimum of around, try to 3 to 4 anchors should suffice for this. You can take intralabral through the thing as I was taught by my professor during my hip scopies. That too helps me and get a proper junction. So glenoid instability is much less common condition compared to anterior shoulder instability, and they are classified as fixed or recurrent. And then the posterior shoulder instability can also be a unidirectional, which is less common, and bidirectional and the multidirectional are more common. There's various surgical consideration you can find in the literature. And this is a rehab exercise which we should recommend to our patients post-op surgeries, which we thoroughly do in our Center in Sports Science India. And there are multiple patients in which patient has one patient who has not undergone at least 6 months of physical therapy and still experience instability and should be considered for surgical stabilization directed at the underlying pathology. Thank you very much.
Excellent. Any questions?
So for posterior instability, do you routinely evaluate for the acromion morphology? Because there is this current concept that the acromion morphology also should be considered for posterior instability.
Not routinely. I don't do it routinely. But
What do you mean by acromion morphology? You're talking about downsloping acromion?
Yes, there is increased acromial tilt, or we'll have to plan for a scapular osteotomy along with posterior instability repairs.
that is when you have a severe bony lesion. That is what the classification, if it's a unidirectional or a multidirectional. So in case of a straight cut labral tear, you don't have to do those things. But if there is some torsional difference and all, that at that time I think we should consider. What do you think, Dr.
Yeah,
Karthik?
I think what you're talking about is a dysplastic glenoid.
Yeah.
A dysplastic glenoid which is more retroverted.
Yes, sir.
That is a situation which you will realize as soon as you get your MRI, and the patient also, you will know from childhood you might be having a recurrent posterior dislocation. Yes, so those patients obviously will need a linear osteotomy. It's a very, very rare condition which you should not miss. It's not a common thing.
Yes, sir.
Sarthak, have you seen reverse heel sac lesion when you do your posterior instability?
Very rarely, sir. I do look for, but I have not done many of the implicit reverse life.
Sir, any of these patients were epileptic, and did you have to change your mode of treatment? In these
I have
posterior
not come across epileptic with the posterior stability. So maybe I think for that you have to do an open lateral jet with the posterior support. I'm not sure. What do you think, Dr. Karthik?
If there is bone loss, we might have to do some posterior bone block.
Yeah, that's
again,
what,
it's a,
like
again, it's a rare
posterior bone, like a lateral jet, posterior bone. Like,
yeah.
yes.
But they also have a reverse heel sac where we might have to do a McLaughlin.
Yeah, I have not.
Thank you, Sarthak. Wonderful.